Good morning, everyone. My topic is on telemedicine and neuroophthalmology. Telehealth is the use of technologies for long distance clinical care, health related education, public health, and health administration. Telemedicine is a subset of telehealth which delivers remote patient care through two-way communication between the patient and healthcare provider through telecommunication technology. The revolution in information technology has made a positive impact in medical field where accessibility is a major problem. Many of the trained ophthalmologists are based in urban areas, catering to just 10 to 15% of population requiring such services. Majority of our population, 80%, resides in rural areas which have very little or no access to tertiary eye care. Teleophthalmology is a techno-savvy method where medical facility is taken to rural and remote areas by using computers, video conferencing, and internet. It was very useful during COVID-19, which warranted social distancing. Vision centers provide primary eye care services with the help of trained ophthalmic technician at an affordable cost. It is connected with the base hospital through internet services to enable direct patient consultation and interaction with the ophthalmologist. Eye care services are accessible and affordable by reducing travel cost and time for the patients. And patients who need further evaluation and treatment at specialty services are referred to the base hospital. So, neuroophthalmology involves diagnosis of vision threatening and potentially life threatening diseases where delay in diagnosis or treatment can be devastating. Teleophthalmology helps in picking up patients who need urgent and timely intervention. We aim to study the effectiveness of telemedicine in neuroophthalmology. It was a retrospective observational study. We analyzed data of patients referred from 13 primary vision centers in rural areas to neuroophthalmology services at Aravind Eye Hospital, Coimbatore, over 18 months from January 21 to June 2022. Clinical and demographic profile, diagnosis, time between referral and reaching base hospital were analyzed. Total of 335 patients were referred from vision centers to base hospital. Out of them, 88% reached the base hospital and 71% needed neuro-ophthalmic management. 59% of them were males, and the major diagnoses were cranial nerve palsy, which was maximum, followed by cerebrovascular accident, papillary edema, optic neuritis, non-arthritic anterior ischemic optic neuropathy, ocular myasthenia, and traumatic optic neuropathy. Other diagnoses were primary optic atrophy, secondary optic atrophy, nutritional optic disc failure, and toxic optic neuropathy. And majority of patients, around 50% of them, reached base hospital within 1 to 3 days of referral. And the main presenting complaints were defective vision, double vision, drooping of lids, field defect, headache, and eye pain. The clinical findings based on which patients were referred were extraocular movement restriction, ptosis, pupil abnormalities, and disc abnormalities like disc edema or disc failure. Among 65 patients who presented with cranial nerve palsies, maximum were 6 nerve palsy, followed by third, fourth nerve palsy, lower motor neuron facial nerve palsy, and multiple cranial nerve palsies. Out of 27 patients who presented with CVA, 20 patients presented with field defect, 5 with cortical blindness, and 2 with vertical gaze palsy. Out of 46 patients who presented with sudden onset defective vision and RAPD, 15 patients had optic neuritis. 20 patients presenting with headache, transient obscuration of vision, and bilateral disc edema had papillary edema, and 2 patients had intracranial space occupying lesion, and 10 patients presenting with drooping of eyelids and or intermittent double vision were diagnosed to have ocular myasthenia. Toxic optic neuropathy was found in 8 patients, out of which 4 were tobacco alcohol induced and 4 were ethambutol induced optic neuropathy. All of them were evaluated and treated accordingly. Heather-Moss et al. Study surveyed 135 practicing neuro-ophthalmologists in US, comparing the telehealth utilization during pre-COVID, early pandemic, and 1 year later. 1 year into the pandemic, neuro-ophthalmologists still maintain telemedicine utilization at rates higher than pre-pandemic levels. They found confrontation, visual fields, ocular alignment, and pupil examination were not suitable for teleconsultation, but it improved access to care, continuity of care to the patient. Telemedicine has been proven to be cost-effective, accurate, and reliable method for screening and monitoring in patients with ROP and diabetic retinopathy. Teleneuroophthalmology can be used for follow-up of idiopathic intracranial hypertension, migraine, optic neuritis, and anterior ischemic optic neuropathy after initial evaluation and treatment. It will help patients in remote areas to access high-quality, cost-effective neuroophthalmic care. It will be useful in triage, diagnostic consultation, and long-term treatment monitoring. It is an important alternative for elderly, immunocompromised, and mobility challenged patients. The essentials for teleneuroophthalmic care are best corrected visual acuity, color vision, central fields by Jerem screen, pupillary examination with swinging flashlight test, fundus examination with a high quality fundus photo. Pupillometer, Humphrey Visual Field Analyzer, and OCT can be incorporated in future for furthermore evaluation. So telehealth is increasingly recognized, and teleophthalmology does not substitute but supplements and complements in-person neuro-ophthalmic care. Many advantages has been explored during the pandemic, and it will continue to serve the rural population. It is an excellent tool in triaging patients and to sensitize them to get immediate medical attention who are otherwise reluctant to visit a hospital. So it is very helpful in neuro-ophthalmology services where timely diagnosis and intervention is very important, which will be vision and sometimes life-saving. Thank you. These are my references.